Hello, Menopause Chicks. I'm Dr. Anna Garrett, and I am thrilled to be here with you this afternoon for office hours. And thanks so much to Shirley for inviting me. I know Menopause Chicks has a lot of new members, and many of you haven't been here that long, but I've been around with Shirley since we both kind of got started in what we're doing. So I think I did one of her first webinars back in the day. So I'm going to answer questions for you guys. I do want to be clear about one thing, and that's that if you have a very specific question about your particular medical condition, I really can't answer that without having some history about you. So feel free to get in touch with me and schedule a consultation if that's something that you feel would help you. But I'm happy to take any general questions. So let me tell you a little bit about me while people are joining on the live. I'm a doctor of pharmacy by training, and I have had my business for almost 9 years, and it is called dranagarrett.com, and you can find out a lot more about me there. And I got on this journey because I am a woman in midlife, although sort of moving toward the end of the spectrum that's a little bit older. And as a pharmacist who was doing health coaching with women, I noticed that a lot of them were being really heavily impacted by hormonal changes, or sometimes they didn't even know that that was what was going on, but they would come to me and they would say, you know, I'm about to turn 50 and this is going on and that's going on. And so I decided when I started my business that not only did I want to coach women in midlife to help them move into that last chapter of their lives a little more gracefully, but that also I could use my pharmacist knowledge to help with hormone imbalances. And so that's what I've been doing. So I offer a wide variety of services around hormone balancing. I have all kinds of testing. I've got a weight loss program. I do custom management plans for my clients. And my big project this year was publishing this book. So I'm an author in Mokita. I wrote the chapter on hormone testing. And then I also published my own book, which is called Menopause, The Savvy Sister's Guide to Hormone Harmony. And when I wrote it, I really had in mind for it to be like the what to expect when you're expecting for perimenopause. Because, you know, when we got ready to have kids, we all went out and bought what to expect when you're expecting, and that was sort of the Bible for, you know, how pregnancy was going to go. And what I realized was that there was nothing for anybody on the other end of the spectrum, and that women were wandering blindly into what didn't even have a name for them. I mean, perimenopause, the term perimenopause is relatively new. So I wanted to change that and let women know what was coming and how they could help themselves best. So that is the story of how I got to where I am. My book is available on Amazon and Barnes & Noble and Kobo, or at perimenopaussebook.com. So I hope you will all pick that up, because it is a great, it's a great combo with Mokita, because Mokita is very different. So let's see if we have any questions. Hello, Shirley. Thanks for having me here. I'm going to start off just by answering some of the questions that I got by email until we wait for some to come in during the live portion. I got a head start on some of these because there were a lot. So I've been trying to answer some of them over the last few days. And the ones I did not answer were the questions I felt might be most pertinent to a lot of people. So here is a question that came in. Understanding that we're all very different and respond differently to everything, I have started HRT, which means hormone replacement therapy. And I'm wondering a general consensus if anyone has had initially period cramps and how long did it last for? And about how long did it take to see your symptoms of postmenopause subside? So when you start any type of hormone replacement, remember that your body has to achieve a new balance and a new normal. And so for me to answer this question specifically is impossible, because everybody does respond differently. So you're adding in estrogen and progesterone more than likely. And if the estrogen dose is higher, or too high, you could potentially have period cramps. Or you could experience, anything, heavy periods, whatever. I find that the response to treatment is pretty quick. I would say that people start to notice a change usually within a minimum of 2 weeks, a change of some sort. Maybe it doesn't cause all of the symptoms to go away, but something starts to get better or potentially worse. So it's usually a good idea to check in with your doctor if any of those things start to happen, and let them know that things are not progressing in a way that you expected. I think it's really important for women to be able to advocate for themselves with their healthcare professionals, because ultimately you are in charge of your body 24/7. And if you are not getting the results that you need, then you need to speak up and say something, because that is the only way you are going to get the results that you want. So here is a question about anxiety, and I get lots and lots of questions about anxiety. This person said they've had it before and could manage it well, but in the past year it keeps getting worse. My throat tightens and my mouth gets very dry so that I can't swallow, and that makes me very anxious. Does anyone here ever have this feeling? So I would say anxiety is probably in the top 3 experiences that women may have in perimenopause. And the reason this happens is because progesterone levels drop, and progesterone is your calming hormone, and so it's not in your brain to keep you from being anxious. The other thing that can happen is that your cortisol levels may be dysregulated. And so cortisol and epinephrine and norepinephrine are your stress hormones, and your body needs certain nutrients to be able to break those down and metabolize them and get rid of them. And if you are lacking in nutrients, and it's usually B vitamins, then that can also increase your level of anxiety, because those compounds just hang around instead of breaking down and being eliminated. So there are 2 things to look at there, the progesterone and the cortisol. And sometimes if you have hyperthyroidism, you can have anxiety, but I find that that's not super common in women. Mostly they have hypothyroidism. So I just wrote a 4-part series on anxiety, and it's on my website, dranagarrett.com, and it's 4 weeks in a row of blog posts, the last of which was last Thursday. Comes out every Thursday, so if you look back for 4 Thursdays, you're going to find the whole series. And there are some uncommon causes of anxiety, like low omega-3 levels. That's one. The B vitamins, that's another one. I can't remember what they all were, but if you want some help with anxiety, there are a couple of routes you can go. You can try breathing exercises. That's helpful. Something as simple as having a gratitude journal can also be a way to lessen your anxiety. If you want to go more into the supplement realm, supplements like L-theanine are helpful. That's a compound that's found in green tea. Let's see what else. Magnesium can be very helpful. It's a calming mineral, and you take it at bedtime, and that can really help things quite a bit. And then obviously replacing any nutrient deficiencies that you have. And then there's the medication route, and I know that gets talked about quite a bit on here. And so, there's antidepressants, there are drugs like benzodiazepines. None of those really help the root cause of what's going on, even though they can help mask the symptoms really effectively. The problem is it's really hard to get off of, and can have some long-term downstream effects, like potential increase in risk for dementia, and just generally hard to get off of. I'll just leave it at that. Antidepressants are not addictive. So I know that people say that they are. They're not. They're just hard to get off of because they change your brain chemistry, and they can suppress your brain's ability to make its own chemicals like serotonin and dopamine. And so from that standpoint, that's why they're hard to get off of, because your brain needs time to ramp that production back up. And so they have to be tapered very, very slowly. And in my experience, Paxil and Effexor are the hardest ones to get off. Okay, so I'm still looking for some questions. Let's see, here's another one. Has anyone in this group had experience taking Estalis? And I had to actually look up what this was, because what is available in the United States may be a different name in another country. I was recently prescribed it at 140/50 a day as a patch. I plan to discontinue it and ask my doctor to prescribe Prometrium along with some form of estrogen. My critical issue has been sleep lack, and this has done nothing for it. I was alarmed to read that one of the side effects of Astralis can be rapid weight gain. So Astralis is estradiol and norethindrone combined in one patch. And norethindrone is a synthetic progestin. So when it comes to sleep, it's not going to be nearly as helpful as something like Prometrium or a compounded progesterone would be. It is not your calming hormone. It is progesterone's chemical compound with a little change made so that it can be patented and marketed. So the estradiol part of this I think is fine, but the Prometrium would definitely be the way to go as far as sleep goes, because when progesterone goes through your liver, and Prometrium is progesterone, when it goes through your liver, it's broken down into 3 different compounds, one of which makes you drowsy. And so that is why oral progesterone helps make you sleep, but topical progesterone does not do nearly as good a job. So if you have issues with sleep, then oral progesterone is the best way to go, in my opinion. You do need a prescription for it, so you will need to see your healthcare provider for that. Let's see. Can one take Vagifem? This is from Larice. Can one take Vagifem if you're still in perimenopause? There is a warning to take only if you are in menopause. Yeah, I saw this. I saw this question, Larice, on the site earlier. You know, if you have vaginal dryness, I can't think of a single reason why you wouldn't be able to use it in perimenopause. It is a local estrogen, so it's not going to be absorbed into your body to any great extent. You know, I'm trying to think of why there would be a warning to only use it in menopause, and perhaps it's because perimenopause tends to be a state of high estrogen levels and not low. And so there may be concern that you would be raising your estrogen levels in some way. But as you progress through the menopause transition, the closer you get to being menopausal, then the more likelihood is that you may experience vaginal dryness. So I would revisit that with your doctor if they don't want you to use it. The other thing you can do is on the internet, at the Bezwecken Company, spelled Bezwecken, they have vaginal inserts that have DHEA and estriol in them, and that can be a very nice solution for vaginal dryness as well. There's another Dr. Anna Kabeka, who has a website. She is an OBGYN and does a lot in the menopause space as well. And she has a cream called Julva, Julva, and its active component is DHEA. It's got some other botanicals in it, but the DHEA is what's doing the job. And so DHEA and estrogen both help plump up vaginal tissue so that you are actually fixing the root cause of what's going on. So yeah, I would re-ask about that, because I don't know of a reason why you shouldn't be able to do that if you're experiencing vaginal dryness. Let's see. This is from Cindy. Cindy's a member of my group too, the Hormone Harmony Club. So if any of you want another place to ask questions, that is another place for you to go. And Cindy's been in my group forever, I think. And her question is, after losing estrogen, our lubricant, Is there anything we can do about stiffness in our muscles besides eating foods with omega-3s and doing yoga stretching? So muscle stiffness and joint stiffness is a sign of low estrogen, and so estrogen replacement can be super helpful for that. Something else that may help is magnesium, because stiffness can mean that there is a depletion of magnesium. Omega-3s are helpful. Boswellia, Boswellia, is an herb that also can be very helpful for joint pain. And then curcumin has been helpful for a lot of people. It's anti-inflammatory. You can sprinkle it on your food. You can take it in a capsule, but it's a nice natural approach to inflammation. Let's see. This is from Sally. I would like to hear or read comments about what to expect when your BHRT dose changes. Much of my experience and symptoms are complicated due to extreme grief. How long does it take in general to get used to the new bias dose? Well, so I think this question is more than likely about what extreme grief does to you. And so extreme grief and any kind of reaction like that is going to ramp up your cortisol, and cortisol over the long term, as you go through a stressful time, your cortisol levels come up, which is anti-inflammatory, and then as they come down, as your body can't keep up with the demands of the stress, you then can start to have experiences where you start to have more inflammation. I realized that answer just didn't make any sense. So the grief part needs to be addressed for sure, because that can complicate the hormone imbalance picture. When a dose changes, again, it's kind of like starting a dose. I would say that you would notice a change within 2 to 3 weeks if that dose change is a good one for you. BHRT, for those of you who don't know, is bioidentical hormone replacement therapy. It and HRT get used interchangeably a lot of the time. And so generally, if I'm saying HRT, I'm referring to BHRT. I know that there are a number of women in this group who are using traditional HRT, which would consist of perhaps a synthetic progestin and Premarin. So that is more of a traditional regimen that we think about. So here's a question about pellets. I'm not going to read the whole question because it's really long, but here are my thoughts on pellets. So pellets are little things about the size of a grain of rice that are made in a compounding pharmacy, and they are loaded up with hormones, usually testosterone and estrogen, because in this scenario, progesterone is usually given orally, so you can't put that in a pellet. But and you may have DHEA in there as well. But the way pellets are done, a small incision is made in your butt, and the pellet is stuck in there, and then there's a stitch, and it holds it in there for 3 to 4 months. And this is a really convenient way for some women to do hormone replacement because it's good for 3 or 4 months. Well, there are a couple of issues with that. I don't recommend starting off that way, because if you don't have the dose right and you put that pellet in there, then you're stuck with it for 3 to 4 months. And that can be a very unhappy time, especially if your testosterone dose is too high. So I don't recommend doing pellets until your dose is stabilized. The other issue with them is, when you first get the pellet, your hormone levels go high, and then they start to come down, and sometimes they don't last the whole 3 to 4 months, and you're not feeling so great by the time the end of the pellet comes around and it's time for your next appointment. They're also pretty expensive, so it's definitely something to check out if you're on a regimen that you've been on for a while and you want something that's more convenient. But just beware that you know, some doctors' offices will make it sound like it's the greatest thing since sliced bread, but you need to be aware of what potential issues are. Let's see. This is from Chrissy. I was told by a physician to take estrogen in the patch form and the opposite from a holistic doc to take progesterone in the oil form. Help, really two different solutions. So by the way, haven't done either, and I'm just confused. So this is a very common scenario. The first question I would want to know is whether Chrissy had had a hysterectomy, because if a doctor was recommending estrogen by itself and she still had her uterus, that would not be a good medical choice. If you have a uterus, then if you're going to go on estrogen, you need to be on progesterone or a progestin to counteract the effects of the estrogen on your uterine lining, because that can set you up potentially for uterine cancer. So that would be my first comment about this question. Some women do very well with progesterone by itself, especially when it comes to hot flashes. And there's a book called What Your Doctor May Not Tell You About Menopause by Dr. John Lee that was written in the 90s, and he has since passed away, but he was a pioneer in the area of progesterone research. And so he was very much about just trying to get away with progesterone on its own. And I think this question kind of points out, you know, having too many cooks in the kitchen. So if you know, the question would be, well, why would you see two different physicians for the same issue? And I can understand if you weren't getting any satisfaction from the first one, but you know, if you're asking the same question of 5 different people, you may get 5 different answers. And depending on what Chrissy's situation was, I might have given a third answer. And so this creates a lot of confusion for women. So I would say find one healthcare provider that you trust. And, you know, there's no harm in going and having a chat with them and finding out what they know about hormones and sort of gauging your gut level of comfort with their ability to provide the care that you need. And I fully understand that that care is not available to everybody in all parts of, you know, the United States and Canada, because a lot of doctors aren't trained in how to provide hormone care. And this even goes for OBGYNs, which, you know, we expect OBGYNs to be the hormone experts. And a study came out probably 18 months ago that the American Association of Retired People went and interviewed OBGYN residency programs, so the training programs that our hormone experts are going through. And what they found was that only 20% of those programs actually provided any sort of specific hormone training at all. And of that 20%, almost all of it was elective. And so, you know, these physicians are coming out and they just don't get trained, and it's not their fault. It's the way the curriculum is set up. Part of it is the way the medical system is set up, at least in the United States. Our physicians are expected to see a patient in 7 to 10 minutes. And in that amount of time, there's just no way to get into a really deep conversation about what a woman is experiencing and what she wants for herself. And so that's why sometimes alternative providers like me or chiropractors or naturopaths can be a really good choice, because they generally don't take insurance, so they're not under the pressure from the insurance companies and can take the time that is needed to really get into your specific situation and what your goals are. Are there any at-home saliva hormone tests I could use? Which would you recommend? And then somebody else asked about all the other hormone testing methods. And since I wrote the chapter in the book, I'm going to talk about hormone testing as soon as I have some water. So hormone testing generally boils down into blood, saliva, and urine. And all of them have their benefits and all of them have their drawbacks. So if we are looking at doing baseline hormone levels for someone, then any of those methods is probably going to be okay. In my practice, I use a dried urine test, and it's called the Dutch test. And the reason I use that is because not only do I get the levels of sex hormones, but I also get to see the metabolic pathways that your body uses to break down those hormones and eliminate them. I also get some organic acid markers, as well as a nice full look at your cortisol picture and what's going on with that. Excuse me. So I like that test for that reason. I also like it because it's done in the privacy of my client's home. She just ships it back to the lab, and then I get the results. Saliva tests for baseline are fine. They are, the cortisol part of that is actually considered the gold standard, although the Dutch test has certainly made headway in that. So it's a really good way to check cortisol. And then blood testing can be great because it's usually covered by insurance. And for baseline, it provides, all you need. What you need to know is that the timing of the test matters. And so from my standpoint, I want my clients doing testing on day 19 to 21 of their cycle, assuming that it's a 28-day cycle. And that is because the progesterone level is, if she's ovulated, is more likely to be, that's its highest point during the month. A lot of my clients aren't ovulating anymore, or they're doing it very sporadically, and so we just end up doing the test at any time during the month. But for my younger ones, I definitely like to try to get that progesterone bump on the test. Sometimes people are having irregular periods, and I'll have them get an ovulation predictor kit and use that to try to time the progesterone peak. But if we, don't get anything for a couple of months, we just go ahead and do it. So the pitfalls of these tests are, number one, on a saliva test, you can't use it to follow up topical progesterone. And the reason for that is that topical progesterone gets sequestered in fat tissue. And so if you're doing a saliva test, you are going to get this just massive number on the test, and it freaks people out. And it has caused many a doctor to lower a dose that definitely didn't need to be lowered because they didn't know what they were looking at. Blood testing for progesterone is also faulty because the drug is sequestered in fat. It isn't released into the bloodstream very effectively, and so it doesn't register on a blood test very well at all. And I've seen many a woman get her dose increased dramatically because of that, because the physician or other healthcare provider didn't know that that was not the right test to use. You also can't use a Dutch test to follow up progesterone. So the best way to do any kind of monitoring for progesterone is to use a blood spot test, and that basically is sticking your finger with a lancet, because it's capillary blood at the right under your skin, and you put the spot of blood on a card, you let it dry, and ZRT is the lab that I use to get blood spot testing. So that's the best way to do that. Topical hormones are just tricky. So definitely work with somebody if you're going to order a test kit. And so that kind of brings me to another issue that I feel pretty strongly about. And that's that I don't think hormone management is a very good do-it-yourself project. There's a lot that can go wrong. And especially with the Dutch test, there are a lot of nuances that can be pulled out of that test that don't show up on the lab comment section. So the tests are very expensive. I mean, they're anywhere from $160 to $325, depending on what you get in your test kit. And I just think that's a big investment to not know what you're doing. So I believe that it's important to pay somebody who knows what they're doing, because I think you'll get further on your path than you would otherwise. And I'm not saying that just because that's what I do for a living. I'm saying that because I want you to get the best outcomes you can for the money that you're investing. And I think that's the way to do it. So that's my 2 cents on that. There is Cindy. I'm tuning in from Montana. I'll try to watch more later. Well, enjoy your time in Montana, Cindy. Let's see. This is the very first question I got. This is from Pamela. This is in no way meant to be provocative, teehee. And with everything, there are exceptions. But my question is, aren't the hormonal changes we are going through just as normal and natural as teenagers going through puberty? It happens to all of us. It's not an illness. It's part of this time of our lives. I understand using HRT like methadone is sometimes used to help someone get off heroin and then slowly wean them off methadone. But I don't understand simply replacing hormonal losses forever. That seems to be something that is just done, but maybe I just don't know enough about it. When I hear people refer to replacing missing or lost hormones, it sounds to me like it's based on a premise that this shouldn't be happening and could be an attempt to bypass a natural process. I understand one could call an illness natural, but I mean, it is a part of every woman's life. Thank you. I look forward to listening. So I think this is a great question. And in a perfect world, all of our hormone levels would fall very nice and neatly together, and there would never be anything out of balance. Unfortunately, in a world full of toxins and crappy food and stress, that doesn't always happen. So as Shirley likes to point out, 20% of women sail through menopause and never have anything but their periods stop, and that's great. Another 60% have one or two symptoms that go along with that transition, and they manage to get through it with nothing. But then there's the 20% whose worlds get turned upside down. And the question of whether or not to replace hormones is really a quality of life one. And there is no way for us as the collective universe of women to judge a choice that someone else makes for themselves. And so I've known women, like I met a woman from the UK who started a business where she goes into the workplace to talk to women about menopause and managers so that women feel safe coming forward if they have issues that need to be dealt with. And she was an HR manager, and she had no idea what was going on with her. And her brain fog got so bad that she ended up having to leave this high-level job. And that's the kind of stuff that shouldn't happen, but it does. And so we have mechanisms in place and medications in place that can alleviate this. And so if someone's quality of life is being adversely affected by hormone imbalance, I believe they should first start with looking at their lifestyle, because you can't out-medicate a bad lifestyle, and that would include stress management, because it's my opinion that stress management really is underlying probably 99% of what we see with hormone imbalance. And you know what? Stress levels aren't easy to change all the time. So beyond lifestyle, then we can look at using supplements, but beyond supplements, then hormone replacement is a good third alternative if everything else has not worked. And there are other reasons to look at hormones, and I don't advocate starting hormones for bone health, but they are estrogen is very good for bone health. We see so much osteoporosis in women who are postmenopausal because their estrogen levels fall and they're not doing enough weight-bearing exercise to keep their bones healthy, or they're not eating the right foods to make sure that their bones get the nutrients they need. Cardiovascular disease is the #1 killer of postmenopausal women, and so estrogen is also involved in that. So there's a body of evidence that says, you know what, for cardiovascular risk, estrogen is a good thing. And now there's starting to be more work done in the area of dementia, because women's brains are very sensitive to estrogen. And there are some people with genetic variants where you mess with the levels of estrogen and, they become suicidal and all kinds of things. So, I like to educate people and let them know what the alternatives are, but I have to believe that everybody knows their own body best, and that a along with their healthcare provider, that they should be allowed to make the choice that they need to make. And yes, we all will go through it if we live long enough. So let's hope that we all do go through it, because I'd like to be hanging out with you guys a lot longer. And I hope that was helpful. It was kind of a long answer. Let's see. Here's a question from Linda, and I answered it online, but I'll go ahead and answer it here too. This is another one I had to look up. What is your opinion on Covarix? Oops, no, I don't want a phone call. Covarix HRT. I was on it since my ovaries were removed in 2000. Had a hysterectomy at 27 in 1978. Felt great on it, no side effects. Mammogram done yearly, no problems. My doctor insists I should be coming off them to start a Climera patch, which is an estrogen patch. I've given it a good try, but nightly hot flashes, sleepless nights, emotional yuck. My original doctor told me I could stay on it for life if I had no problems. Opinions, please. So my guess is that, well, Covarix is an oral estrogen and an androgen, a form of testosterone in one pill. And so my hunch is, without knowing the full story, is that the doctor wants to move to a patch because with oral estrogen, that has to travel through the liver to be metabolized. And in that process, it affects the clotting factors in your body, which can lead to an increased risk of blood clots, heart attacks, and strokes. And this is true for all oral estrogens, whether they're bioidentical or synthetic. However, with a patch, you don't run into that problem because it never goes through the liver. It's put on the skin, goes into the bloodstream, and does not have to be metabolized in the same way. And so the safest route with estrogen now is to go a topical route. So a cream, a gel, a patch, and to get away from the oral form. So that is my best level guess of what this doctor may be wanting to stop the Covarix for. Unfortunately, the Climera patch does not have any androgens in it. And so to get some androgens, that would require a testosterone cream or injection. So there's a couple of choices with testosterone replacement. And those are topical cream and then a weekly injection. There are no commercially available products. Like for men, they've got the underarm stick, and that's all they got to do. But there's no commercially available products for women. So you're either using this vial, or a compounding pharmacy has to make you a prescription for a topical cream, which can be very effective. But I don't know if there'll ever be a product for women. I'd like to think so, because as I understand it, the last North American Menopause Society meeting, there was some more data presented about testosterone in women, and it was favorable as far as the benefits. So stay tuned for more on that. Y'all are letting me off easy. Let's see if there's anything else. So Cindy also asked about sleep, and I know that you had office hours on sleep, which I probably should have been on earlier today. Talked about testing. Someone asked about hormone balancing diet, and did I know what it is? There are a lot of people out promoting hormone balancing diets. Dr. Anna Kabecka is one. Dr. Sarah Gottfried had one as well. If you look at these diets, most of them are based in clean, unprocessed food. Anna Kabecka's is more slanted toward the keto side of things. Just getting rid of sugar can make a huge difference as far as hormone balance goes. My experience, at least with my people that I work with weight loss on, is a low glycemic index diet is also very helpful, because it helps stabilize insulin levels. And at the root of all weight gain is an insulin problem. It doesn't mean you have metabolic syndrome, doesn't mean you have diabetes. It just means that your blood sugar is not well managed, and that your insulin is out of whack for some reason. Let's see, is taking estrogel and prometrium related to breast size increase? And also, is estrogel truly BHRT? So estrogen does increase breast size, and this is especially true if the dose is too high. So progesterone is not the cause of that. The estrogen is. Estrogen promotes the growth of tissue. And estrogel is, in fact, bioidentical. Okay, so here's a question from Heather. Would it be beneficial to take estrogen and progesterone together after a complete hysterectomy? And this comes up a lot. So when you have a complete hysterectomy, your ovaries are removed, and along with your uterus, and so you go into instant menopause. And this is really, really hard on your body. I have a whole chapter on hysterectomy in my book just because I think it's a topic that women don't have enough of an in-depth conversation with their doctor about before it happens, and you really need to have that conversation. So the old school thinking is, well, if you don't have a uterus, you don't need protection from uterine cancer, therefore you don't need progesterone. But my personal opinion and the thinking that's starting to shift is that, well, progesterone provides a lot of anti-anxiety relief, as we have talked about. It's great for calming moods. It's good for bone health. It's good for nerve health. So there are a lot of reasons to be on progesterone beyond uterine protection. So I generally recommend that people be on progesterone even if they have had a hysterectomy. And this is the conversation that needs to happen before the hysterectomy. So you need to know what your doctor's plan is as far as hormone replacement. If you're keeping your ovaries, then your body will still be making some estrogen and some testosterone, so it's not as hard on your body. But you can pretty much plan that in 4 to 5 years that your ovaries will fail because the blood supply usually gets disrupted in some way during the surgery. I have no idea what I was going to say. Welcome to my menopausal brain. Let's see. So yes, the conversation. So you want to know, like, some doctors will basically put an estrogen patch on you when the surgery is finished, but then some like to discharge you and kind of wait to see what happens. So you need to know what your doctor's philosophy is on hormone replacement, because the last thing you want is to find yourself discharged from the hospital and all of a sudden all hell breaks loose and everybody's going, oh, well, I think we're going to wait 6 weeks, because that's just, to me, that's cruel, cruel and unusual punishment. So that is just my 2 cents worth. But yes, there is a whole chapter in my book on hysterectomy. And the reason I put it in a book for perimenopause is because perimenopausal women are the ones who are most likely to have a hysterectomy. Let's see. I think that is most of what I had. Oh, here's another one. Okay, from Susan. I was on Bioidentical HRT for 10 years at 40, prescribed by my GP. I'm off them. How do I protect my cardiovascular system and bone health? And that's a great question. So for bone health, my personal opinion is weight-bearing exercise is the best thing there is. And, walking is great and other forms like that. But I really recommend weight training. And when I mean weight training, I mean working with a trainer and lifting heavy weights. I managed to reverse osteopenia completely by doing that over a period of 3 years. So that is the best thing, in my opinion, for bone health. Also supplementing with vitamin D with K2 to keep your vitamin D levels up to protect your bones. And then cardiovascular health, I would say exercising is great for that. And then making sure you're eating a diet that's well-rounded and healthy and clean, unprocessed foods. Stress management is also very important for cardiovascular health. I should probably do a whole webinar on that, but maybe another day. So that is what I have for you. Do you guys have any other questions? I see that there are 13 of you on here, so surely somebody has a question. Well, I have enjoyed being here. If you have any follow-up questions, feel free to post them on the thread that's in the Menopause Chicks group. I also posted a video today about compounded hormones and that I did with a friend who is a compounding pharmacist to talk about, are they safe? Why is my doctor telling me they're not safe? All that kind of stuff. So we get into a lot of specifics about that. Let's see. Carolyn Dix, this is recorded. Yes, this is recorded. And it'll be available in the units section. I think unit 1 is the office hours. Sherry, thanks for your recent posts on anxiety. Very helpful. Yeah, I enjoyed writing that series. I learned a lot. I went to a School of Applied Functional Medicine retreat, and we did a whole morning on functional causes for anxiety, and I got so much information out of that. So I decided to make it easy on myself and write an entire blog series on it. So always looking for topics. Okay, ladies, I've really enjoyed spending this time with you. I'd love to do it again sometime in the future. And again, Shirley, thank you for having me. And you guys have a wonderful American Thanksgiving, if that's your thing, and wonderful Christmas and Hanukkah holidays. And I will see you in the group.